Hello everyone, welcome to the MIDAS ARC Health Economics subgroup seminar. And we do lots of activities. I say we, there's a few of us who do lots of things, and Valerio's here from UCLan who does lots of things, and Misael is here who also works at Lancaster. So we have a bit of a core group, but we have lots of members as well. And we actually, when Misael's talking, we'll put the website address in the chat as well, and you can look at the huge range of things that go on within MIDAS and within the health economics subgroup. Lots of different activities, and we do stuff at the ARC fests and different things, and if you don't know what they are, you can also go to the website and have a look and see. But the purpose of today's seminar is that Misael, who is a member of MIDAS, works, as I say, here at the Lancaster end of MIDAS, is going to present a really interesting talk. And I would like to thank everyone for coming along today. I'll thank you again at the end. But the main person to thank today is Misael, who's generously offered to give a talk. Now, Misael, are you happy to give questions? I know you're happy to introduce yourself, but are you happy also to take questions on the way or in the chat?
Yes,
or?
of course, yes.
Okay, so if anyone's got a question and you're too shy to ask it out loud, please put it in the chat, and Valerio and I will keep an eye, mainly Valerio, will keep an eye on the chat, and we'll ask questions on the way or at the end, and we'll handle it like that. Okay. So Misael, I'd ask you please the only final thing is if people could mute while Misael's talking, then it just eliminates when there's a lot of people on the call. There's always one person with a little bit of background noise or a dog barking or something. So if you could do that while Misael's talking, that's great. That's fantastic. So any questions or queries, please stick them in the chat, and Misael will stop every now and then to take questions. So Misael, if you would mind, please now sharing your slide and introducing yourself, and it's over to you.
Right. Thank you very much. So my name is Misael Anaya. I am Peruvian, so I'm here almost half a year working in Lancaster. So my background is economics. So I did my undergraduate, my master, and my PhD in economics, and I am doing health economics years. I work for the Center for Health Economics at York University, and then I went back to Peru. I worked for the economics ministry in Peru, and then I came back here. So I'm really happy to share with you this piece of research, which is not mine alone. As you can see, there are people from York, from Manchester, from LSE, and from Liverpool. This is a project which is ongoing maybe 3 years now. And I arrived in the middle of this research. So most of the analysis is here, half of mine, we can say, and then we receive a lot of comments on this piece of research, and it's expected. Thank you for coming, for hearing this chat. I'm happy to have questions along the way. So the talk of today is the health inequality impacts of marginal health care expenditure in England. Do the poor benefit more? And this is a funny name because we are trying to see if the marginal health care of expenditure is the additional health that is spending in the UK is benefiting more or not, rich people. Then, okay, very good. Health inequality is a major policy concern, and I am glad to discover it's not only the case for Peru, because in Peru it's a huge concern, but also it's a concern for developed countries, so rich countries like England. So I was amazed when I was invited to work in this piece of research, because I was thinking that health inequalities are not so great in countries like England, but it seems to is, and it is a policy concern. The effect of healthcare on inequalities, although it seems intuitive, is not well established in the literature. That's because the analyses were performed using large area analysis, and we'll explain why, what I mean with large area analysis. And still we have a scope to do some research in this kind of questions. It's fairly easy to do here in the UK. We have very good data. And over the years, how the UK has financed their services has changed. For example, up to 2022, we have CCGs, so care commission groups, and now we have ICS, if I remember well the acronym. So it's changing, but it was more than a decade working as a CCG, so this can give us some insights how to examine these inequalities. So the objective of this research is to examine how this health expenditure on mortality varies deprivation group, using a small area unit of analysis rather than large area of analysis. And now I will explain what I mean with large versus a small area stratification. So on the left-hand side, you can see a map. Actually, this is for 191 CCGs because CCGs also merged and so on. But you can see there the deprivation of health by TCCGs. And this is a map was from the Office of National Statistics. And the darker the shade, the higher the inequality. The lighter, the lower the inequality, okay? So here we can see that the Northwest have more, is in the left side of the distribution, so we have more inequality in the Northwest. So actually, according to this graph, I was looking for the actual data, and the most deprived is the CCG in Blackpool here. And you can see here above is Lancaster. Lancaster is below the middle of the distribution, we can say, okay? But in the right-hand side, we can see the stratification of deprivation by a small area stratification. This is using LSOA dataset. The acronym is lower area, something like that. So this is a narrower division of the geography. By comparison, we can say that in the left-hand side, each CCG has more or less 150,000 people. And on the right-hand side, the small area stratification, we have less than 2,000 people per LSOA. And we can see again, if we compare here, for example, this part of Lancaster, this part in the right-hand side of Lancaster, we have that the inequality is not uniformly distributed. So even here in Lancaster, we have more deprived geographical areas and less deprived geographical area. For example, in Lancaster, it's Morecambe, is our, or close to the coast is our areas that have more deprived population. So the message here is that basically, if we only analyze using large area stratification, we will miss these inequalities within areas. So within areas, there is a difference kind of deprivation. Okay. Then, what we did usually in the researches is we rank CCGs from the less deprived to the most deprived. In this case, in the left hand, in this part of the graph, you can see that there are 195 CCGs. So the first fifth will be less deprived, and then the last fifth will be the most deprived. Okay, and you can see here in the right hand side, even in CCG1, which is the less deprived, we have some population that are more deprived. Okay, some populations that are more less deprived. So what we see here is that there is inequalities, there is deprivation within large geographical areas. And of course, the first SDG will have a greater proportion of population with less deprived population, and the last one will have more proportion of more deprived population. So what we did here, cleverly, my co-authors did actually, what we did, they did is to, instead of ranking CCGs, we will rank this small area deprivation. So we will combine the less deprived from CCG 1, 2, and so on, and then we will group that in a group, which is will be the less deprived area. So here we gain in granularity, we gain in precision. So how this can be reflected? How can we feel this kind of analysis? And this is a nice table. It's ordered from the less deprived quintile to the most deprived quintile. So this is 20% of areas that is less deprived, and so on gradually to the most deprived. For example, in the second column, in the large area of analysis, we will have the adjusted mortality rate per 100,000 people. Here, the less deprived quintile, this first row, signals that there are 806 people who die per 100,000 people. If we compare this with the most deprived, the most deprived is 1,069. So the simple difference says, we can see here, that the most deprived has 33% higher mortality rate, okay? So this is what we see here in the large area of analysis. But if we use the small area of analysis, so the less deprived grouped together, so we have a lower mortality rate, 777. And if we compare it with the most deprived, 1,379. This is the mortality rate per 100,000 people. So, and the difference is a striking 77%. So if we compare large area of analysis, the less deprived against the most deprived, we can see that the difference is 33% higher, okay? But using the small area of analysis is 77% higher, which means that if we use bigger geographical areas, we are kind of hiding this kind of inequalities because the inequalities exist within areas. And if you're wondering what will happen in health expenditure, for example, health expenditure, I need to here put some notes. Health expenditure actually is not distributed for a small area unit of analysis, because health expenditure is distributed by CCG, okay? Only exists by large area of analysis. What we did for this last column is to impute that values and take the average. But just to have a raw figures, health expenditure here in the large area of analysis, the difference between the most deprived and the less deprived is 17%. So we can say that the most deprived is receiving 70% more money than the less deprived areas, which seems nice, isn't it? But if we take that, the average is kind of equivalent using the small area of analysis, this is not that big. This is only 8%. So without showing any regression, without showing any sophisticated analysis and so on, you can just feel here that if we use a small area unit of analysis, we can realize that most deprived people is not having 17% of more resources, it's not having 8% more. And their experience is 77% more mortality, which highlights the differences in distribution of resources, if you like, and more strikingly, distribution of health inequalities in mortality rates. If we like to see this in a graph, which a graph can tell some story also, this is the same information, okay? This is the same information, but all in graphs. So in the left-hand side is large area stratification, and we can see here that in the small area stratification, we gain in information because the mortality is steeper than in the large area stratification. So we can see higher mortality for more deprived people using a small area of analysis. And then the health expenditure is shallower, so there is less differences in the distribution of health expenditure that it seems to happen if we use only large area of analysis. Another interesting thing, this is for statisticians or economists, you can see that shading here. This is the confidence interval. The confidence interval is bigger if we choose large area of stratification than if we choose a small area stratification, which means we gain also in precision in our estimates. So it has several good properties to use a small area stratification. And I hope up to now, without showing fancy numbers, that you can feel that health inequalities is greater than we can only realize if we use only large area of analysis, because there is a within area variation on inequalities also. Okay, now I will go to the methods. I know that not all our audience are economists, but this is just to show what we are using, okay? What we are using is instrumental variables, and this is a method to try to disentangle causality, try to say, okay, what we are doing is not only correlation, which I think is good enough, as I said before, but also try to claim causality. So a good instrumental variable has this property. So this is the instrument. In this case, our instrument is distance from target. If you're familiar with the hospital allocation formula, there is a distance from target component of that. What is this distance from target? So there is an estimation of population needs by large area, geographic area, okay? And there is an allocation of health expenditure in the previous year. And there is a gap. It says, look, for addressing this kind of health needs, I will have to have this kind of level of health expenditure. How far I am from this theoretical allocation, but by our current allocation. If I am far, then next year I will give more money. This is the target, okay? The target is given by the population needs, and the actual allocation is estimated by the previous year allocation health expenditure. Then the difference is the target. So the higher the distance, the higher the money increase that this CCG will get the next year. The lower the distance, or even negative the distance, then I will give my resources will increase in it won't reduce, but it will increase less steeply. So I will have proportionally less money than the others. So this is the instrument. The instrument is how far I am from the population needs estimated with this kind of formula. Then this will affect the hospital expenditure per person in a given year, which is fairly easy to argue. And then this hospital allocation will affect mortality. I think this is also fairly easy to argue. So this is the first part. The first part is the instrument should have an effect on hospital expenditure, and then only for hospital expenditure through the outcome. This is the first conditional for a good IB. This is the strong predictor of treatment. This is statistically testable, so we can run a statistical test and we can confirm this assumption. So this is easy. The second assumption is tricky, because the second assumption is that this instrument is not affecting directly the outcomes. This is the X here above. And this instrument is not related with unobservable confounding factors. What is the unobservable confounding factors? We can say, for example, some underlying problems, some underlying maybe behaviors that we cannot observe that is also affecting outcomes. So we are assuming that this is not related with our instrument. There is no problem of observable factor because we can control for that in the regression. But this kind of unobservable factors we cannot test, we can only argue. So you can check this in any standard regression books. But this is the general idea of the method that we are using here. So in our working paper, you can see the test and so on, of why and how we are using this method. And then it comes the results. In the left-hand side is adjusted mortality, and in the right-hand side is our sensitivity analysis using years of life lost. Okay. Here in the left-hand side, we order from the less deprived, so we can say this is the richest quintile, and then to the most deprived quintile, and this is the average effect. We can see here that the most deprived quintile, this is the effect of increasing health expenditure, is a bit lower, or if you can say it's almost the same than the average, and is lower than the middle distribution. So if we will argue that giving more money will benefit more to the most deprived group, then we will find an increasing trend, which is not the case. An increasing trend will mean that the more deprived people are benefiting from health expenditure, which is not the case here. So, and in our sensitivity analysis, we find the same. So who is benefiting more? So the middle of the distribution, not a very rich, not a very poor. So in the middle of the distribution. Certainly it's not the poor who is benefiting more. Okay? How we can compare these results with existing literature? Here we have this research that was published in the left-hand side in 2020. Here the IMD1 is the most deprived quintile, okay? This is ordered from the most deprived to the less deprived. And we can see here that the effect is higher in the most deprived. So previous literature have found that who is benefiting more from health expenditure actually is the poorest. This is what they found in this study. And in the right-hand side, there is another paper that was published in 2022. This is using another method that is called quantile regression, unconditional quantile regression. And you can see here the all-cause mortality. There is at the mean, there is an effect at the mean. This is, we can say, the least mortality group, the middle mortality group, and the highest mortality group. So, and there is an effect you can see when there is more mortality, they benefited more. So this also suggests that geographical areas that has greater mortality are benefiting more from health expenditure. So this is kind of the same story, isn't it? So people who are suffering more from mortality, who usually are from the lowest quintiles, from the most deprived quintiles, are benefiting more. And in the right-hand side also, people who are living in the most deprived quintiles are benefiting more. So,
Misael, do you mind if I ask a question?
yes.
I was just going to ask, maybe could you give people, and on the previous slide as well, maybe give people an idea of, so the change in mortality and the change in years of life lost, those numbers on the axis, what would they mean? So the percentages, aren't they? So it's a 1%.
Yes. So it's a 1%
decrease in mortality, hopefully.
Yes.
Yes.
Yes. So here is we change the signs just for easy to exposure. So the highest effect means decreasing mortality here. So the average is about 0.79. So 1% of increase in health expenditure reduce mortality in 0.8%. So this is the elasticity of expenditure. So what we see here is that in the middle of the distribution is higher than 1. Okay.
Mm-hmm. And what would that mean for years of life lost? I guess sometimes.
Yes, the years of life
I find that easier to think about.
Yes, this is also elasticity. We have in a paper more intuitive results. For example, from linear regression, what we say, how many years we gain for an additional 100 pounds per person. This is more easily to understand, for example. And we do this in the research paper. I don't have the results by mind, but it's proportional to this graph. So we will find the same pattern. So we will just multiply 100 pounds and how much this will reduce in percentage. And I don't remember exactly what are the numbers, but how we interpret this is in percentage. In this graph actually is elasticities. This is the marginal effect of an additional 1% of health expenditure, either in reduction of mortality or in years of life lost.
So these are quite big. These are significant numbers in the population, I guess.
Yes, they are significant.
Yeah.
So what we say is that health expenditure is having an effect in reducing mortality. So for sure, and we are just confirming previous results. There are plenty of results that establish this. What we are trying to discuss here is if that is benefiting more the poorest, so the poorest distribution of people.
So I don't know if you can see the chart, Misael, but there's a question in there. Can you see the chart, or do you want me to read it out?
Let me just check. Maybe I can see. Okay. Are there issues around time lags? We are using, if we are assuming changes in budget have an effect on mortality within a year, in reality, one affects. Yes, ambulance. Okay, what we are using here, there is 3 types of budget. So we have hospital budget, primary care budget, and another budget, which is elective, I think. So there is a 3 budget. We are using the core budget, the hospital budget here. So, and we are using cross-sectional regression. So we are not using panel. It will be nice if we can take panel data and then we can do some differences, for example, in changes in health expenditure and mortality. But that's because these results are not published each year. So, and we are using 1 lakh expenditure. But in any case, what we are arguing is that we are using cross-sectional data, and as you can imagine, mortality is not it's not easy to reduce. So mortality is one of the health outcomes that are very difficult to reduce. For example, let's say that we increase health expenditure this year, so probably this will have an effect in 2-3 year times. So it's difficult to change mortality in only 1 year. So we are assuming that our figures represent, for example, what is happening in the system in a steady period, for example, 5 years time. So that is the reason we are using cross-sectional data. So we are not using dynamics because mortality is, again, is difficult to change. It will be even better. There is a studies who argue that it's better to take the 5 average, for example, expenditure, and then have an effect that in the following 5 years. That could be nice to do, but we don't have data. We don't have data to do this kind of analysis. I am, okay, if that allows, you could go a step further than looking at activity variables. Oh, of course, and go to the individual household measure of deprivation. That could be nice, of course. The message here is that if we have deprivation by LSOA, which is around 2,000 observations, and we have here more precise sense of what is going with health expenditure, it could be better if we have household data or even individual data. Clearly, in England, I'm not aware of that existence, but sure, the lower the level, the more granular, so the better. So I think maybe in the future you can find some other more precise information of health outcomes that could improve, that could even improve our analysis. But this is as much as we can do with the current data set, which is, I think, good enough. And just to have a glimpse of this kind of aggregation can hide inequalities. It could be another interesting question, for example, if this new model of integrated care boards, which is not now 195, I think it's 42. So this is aggregating bigger spaces, isn't it? So this is aggregating. So it's improving coordination, it's improving efficiency, but is that targeting poorer areas better or not? That could be another interesting questions to address.
Misael, there's also a question, thanks to Brendan, there's also a question above that from Raj. Did you see that one?
Yes. Will we know the level of expenditure per household? I think it's difficult to know that. I think it's difficult to... even here, for example, we are not using expenditure per LSOA. We are using expenditure by CCG because how the health expenditure by hospital is allocated is by CCG. So having this kind of expenditure per household, I don't know if that could be possible. Okay, Katarina is.
Yeah, there was one above from Raj about how could, just sorry to interrupt Katarina, but just because Raj.
Yeah, I was saying, like, I think you got confused, but yeah.
Yeah. But how could we ensure that the poorest get more benefits from healthcare than the least deprived, as poorer have got more health issues and generally have less access to health and other services, and there is more mortality among poorer than advantaged groups. So I guess that's quite a big question to answer. I don't know. Is there anything from your survey that would, well, are you going to talk about that in your conclusions?
I think we can say that we don't know. We don't know. We can say that the poor is not benefiting more, definitely. So we need to target more. How to make a better targeting is out of the scope of our analysis. So how to improve? So we can say it clearly, we don't know yet. So we need research.
Did you want to follow up on your point, Katerina?
Yeah, so I was wondering, and I was not sure whether I missed that. So the expenditure data aren't at the LSOA level. So they are still at the highly aggregate level of CCGs, yeah? So how can you then link expenditure? Like, because the mortality data is at LSOA level?
Yes.
Yeah, but the expenditure data is just what it is for the CCG that the LSOA is part of. So we don't really know exactly how much expenditure this specific LSOA had. We only know what the larger area had. So this is why I'm a little bit concerned. How can we then make statements about for these smaller areas, an increase in spending doesn't really make a difference because we actually don't know how much that smaller area got.
Yes, that's right. So we don't know how much this lower area is having an expenditure. So what we are doing is imputing this health expenditure per each lower area level by their CCG. So we match CCGs with LSOAs, and we say, look, you are receiving on average this amount. We are not dividing anything. We are just assuming we are having this, and we are checking with this with mortality. So we are not dividing, we are not doing that. We are just assigning the same amount of this So
yeah, this is the challenging thing, because we just know that area got more allocation. It's not the spending, is it? It's just what they got allocated, or is it what they actually spent?
It's what they got allocated.
Okay. Because with spending, obviously, that's then that would be confounded by what their needs are. So like I can see the logic why spending more allocation, more money being available to poorer people, that fits with the Grossman model, doesn't have the same effect. Yeah, so that's like this less effective producer hypothesis, isn't it? Like if you're more deprived, you're probably less educated, and you're less effective at turning inputs into health outputs. The interesting thing is obviously that there's this peak in the middle. So that, but on the other hand, maybe for people who are least deprived, there isn't really much gain in getting secondary healthcare expenditure because they're quite healthy, so they don't really need hospital services anyway, so it doesn't really make a big difference for them. And maybe when you're in the middle, you can benefit from it, and you also have the ability to benefit from it because you're able to get access to these services and so on. And that might then join in with Raj's question. So how do we make sure that the poor get more? Is not really giving much more to areas which have not very deprived people, yeah. But instead, like we just know we have to send more money there. It will have less of a change, yeah. So the impact will be less. So you might have to send a little bit more than if you were sending it to a third quartile person. But I think that's
yes, we are
all you can say with that, isn't it?
Yes, it's as much as we can say. So we are just saying that we are not saying let's give them less money. We are not saying that.
No, yeah, you have to compensate for the fact that they're less efficient at turning more money into more health, yeah. Yes. So you have to give them more money to make up for the fact that they are less efficient at turning
Yes.
another pound into more health.
Yes.
So you have to give them
So-
2 pounds.
Definitely we have a couple of hypotheses how this could work, and one is this human capital hypothesis. However, we cannot have any means to test our hypothesis. We can say that the message is we need to have a clear message to commissioners. So look, you're having money, but we need to find some creative way that this money will reach also the poorest people in your background. What efforts is the question, the big question. The big question is what else we can do, what programs, what kind of interventions we need to do to target these people. But I agree with you. So this is not the best causal paper that we have. It is not. It's as much as we can do with the data. So we try to be very descriptive of this. And hopefully there are hints. There are hints in our research that signals that, look, it's worth to do this kind of analysis using more disaggregated data, more disaggregated data.
Well, the great thing is that on average, more money is more health.
Yeah, that's encouraging. So we are not
That's reassuring.
And have you had any feedback from the people involved with the allocation or involved, in terms of, does this confirm what they think?
Actually, Richard had some meetings with policymakers. Richard is the here in this work, and they are not happy with the figures actually because they're not happy because they were relying that, look, just give us more money and we are benefiting more poorer people. So that's our main assumptions up to now. But if you are saying that that's not the case, so they are not so happy hearing this kind of news. And also the academia is not happy to hear this kind of news because it's kind of contradicting previous research. But still, we have some contribution to make, I think.
Sorry, Misael, you were busy talking but it's good that people ask lots of questions. But
yes.
We'll let you get on because you've got about there's 10 minutes left. So.
Yeah, but actually, this is the end of the talk. So the last slide, and I hope that at least, given the responses, it seems interesting. So even though we can argue in favor or against, it's kind of interesting thing.
So how does it like the maps you showed at the start? I think maps are great in this sort of area, this sort of type of research at showing people straight away what's happening. I mean, is there any way you could map what is happening at a more local area? I think
we can think of doing maps and include it in our research. Maybe that is a bit of piece that could improve also the appealing of the paper. Yeah.
Has anyone got any more points? Or there might be people on here who actually are policymakers or are involved with local expenditure in these sorts of areas. What do you think about this? You might not want to say, of course, but any more comments or questions?
I've got a comment/question if nobody has another question. Oh, Alan, you go first.
There we are. Can you hear me all right?
Yes.
Yeah. The maps that you showed at the beginning, it didn't surprise me in the least. I live in a fairly deprived borough of St Helens, but I know that in St Helens, the life expectancy in the best part of town and the life expectancy in the worst part of town is 11 years difference. I've been told that originally by the CCG people and now by St Helens Place. To the west of St Helens, there is a borough of Knowsley, which is in fact where I worked for 25 years, which used to be, I don't know if it still is, the second most deprived borough or place in the whole country. Behind, I think, Tower Hamlets in London was the worst. Between those two, though, we only have one hospital trust. The hospital trust, as far as I'm aware, now you could tell me otherwise if you think so, it doesn't spend money differently depending on which part of St Helens you come from or live in, or which part of Knowsley, whether you live in Knowsley or St Helens. It treats everybody the same, I think. And unless you've got evidence, should we say, to say otherwise, then what you're saying doesn't surprise me in the least. Does that make sense? And I don't know how they would do otherwise. I mean, they're not going to. Somebody comes into the waiting room and or A&E and say, well, what part of town do you live in? And they say, oh, well, okay, well, we need to spend more money on you, or we need to spend less money on you because you come from a better part of town. They treat whatever's wrong with you.
Yes, that's right. So we are not saying that hospitals are discriminating for people, but this kind of outcomes could have some explanations. One hypothesis is that people who are, one of the ways is say, look, they are already ill before they come. So this area is ill, so whatever we do, whatever we can treat is not having the marginal effect will be lower with them. So maybe the preventive nature and so on, or maybe other policies, social policies, could have an effect on increasing life expectancy in those areas. So one of the ways saying, look, the health system is doing whatever the maximum they have, but it's not possible to have more effect differentiated on them.
Primary care might be different, by the way, because it just crossed my mind that in St Helens, anyway, we have 4 PCNs, and they're based on areas, and they are pretty well aligned with the good areas and the not so good areas. And it could be interesting, perhaps, if you were to do a similar bit of research on the primary care expenditure, and that might come out very differently.
Yes. There is one piece of research that is currently ongoing. I am aware of that. This is going from another group of researchers who is doing this similar analysis using primary care data. So we will see that their results soon, I hope.
Christine, I think you've got a question. I'm just keeping an eye on the time. Christine, good. Thank you.
Hiya. Yeah, I sorry, I should introduce myself. So Christine Camacho, I'm a consultant in public health. So really interested in this research. I work in secondary care in the NHS. And I think in a way what you've got there as your second bullet point on the slide doesn't surprise me in any way. I think just a little bit hesitant about that conclusion about the poor do not benefit more. And I think just kind of understanding some of the nuances around that in terms of what people have said around kind of comparing LSOA data versus spend at a CCG level, and just thinking about the outcome measure as well. And there is a study that was done by Ben Barr at Liverpool quite a few years ago now that did show that actually increased funding to more deprived areas does lead to reduced mortality. And they specifically looked at mortality that was amenable to healthcare as an outcome measure. So I think there's lots of nuances around this, but I think the headline statement that kind of putting more money into areas of deprivation doesn't help. I'm not, to me, I'm not sure that follows directly from the data that you've presented.
Actually, I agree with you. So one of the hypotheses that Katarina is saying that it's not that we need to spend less, we need to spend more. So we are not here discussing that spending, health expenditure spending is not having any effect in reducing mortality. It is having an effect on reducing mortality, definitely. So what we are saying here is that poorer people are benefiting if we say the average, so the same as the other people. So previously, what the research it's saying is that if you give money to a CCG which is poorer, so there is an average effect, but the poorer is benefiting more than the average. And we are saying no, it's benefiting as much the same of the average, not more than the average. So we liked that we would like to have this expenditure benefiting more the private population, of course. So we need to do more. One solution is to give more money to all the CCG to improve, so to increase this kind of marginal effect population, because they need more money to transform the effects on poorer people.
Mm-hmm.
So
I think there's an there's an interesting point Brendan's made in the chat about you know, people from higher income groups are better at using healthcare and better at getting healthcare and accessing care as well. So if you keep giving them more money, they'll have the first call on it if they're better at getting it. Maybe. I think that was your point, Brendan. Sorry for paraphrasing if I got it wrong. Would that be fair? Maybe how would that be accounting it, Misael? Sorry, Brendan. I know you can talk for yourself.
Yeah, that's right. Yeah, sorry, I couldn't find a way to put my hands up. Otherwise, I would have put my hands up. But yeah, that's right. I think that there is evidence around waiting lists as well. So I know there's been evidence around waiting lists that you've got more people in deprived areas on waiting lists, but also they wait longer on waiting lists as well. Which some of it might be down to individual choice. So if you're waiting for surgery, for instance, and you don't want to have time off because you're self-employed or whatever, then that might be part of it. But I think in general there is evidence that, you know, people on higher incomes do know how to use the system, and it's really complex trying to navigate the NHS. And I know, so in the past I worked in hospital, and you get people ringing up all the time who know who to talk to say, well, have you got any, you know, any gaps on the waiting list or anything like that. So it is a complex system to navigate, and particularly if you've got multiple long-term conditions, then it's even more difficult.
yes, that's right. So richer people could have more means of everything, actually, even from transport, links, and knowledge. And they can have access more service, and they can use the same service that is available to everybody. But some deprived people are using that not because they are prohibited to them. It's just because there are some burden to accessing that of several kind of things. Yes, Katarina.
Oh, I was just trying to say, maybe in a reassuring way for Christine as well, that I think what the paper is mostly showing is that if you aggregate data, you miss subtle detail, basically. So previously, if you used larger areas to look at that relationship, the impact of more money on outcomes was sort of masked by some people benefiting more, but so it made it look as if people in poorer areas, as defined in larger areas, benefited more, but that might be driven by people in the middle, that they really benefit a lot. And then on average, it looks like, because as Alan said, even an area which on average looks poor, there are still pockets of non-deprivation, just like in rich areas, you have pockets of deprivation, so you will still have pockets of okay areas, and if these people are really, as you say, like sharp elbows of the middle classes, good at taking advantage of whatever extra resources come in there, they will benefit more, and it will reinforce inequalities, because you throw money at an aggregate level where you think, there on average there is inequality, but then the people who actually benefit are not the really poor ones, but the middle well-to-do ones, and then you actually make things more unequal again. And then Christine's concern, about, yeah, it doesn't mean we should send more money to poorer areas, but it's basically this equity efficiency trade-off. So if you send money to people that are sort of effective producers according to the Grossman model, yeah, the same amount of money, like £10, results in a higher gain in health compared to £10 in a less effective producer. So if you want to make sure both people have the same gain in health, you have to give the less effective person maybe twice the amount. And people might be willing to do that. So Richard Cookson has done some work on this. People are willing to trade off a little bit of efficiency. Like if you really wanted to just maximize health gain, you should just give the money to the effective producer, basically. But people care about equity, so they're willing to trade off a little bit of efficiency. Like in overall terms, we have less overall total health gain, but we have less inequality. So people are willing to trade off some efficiency for gains in equity. And that's basically what comes out of this. I think it sort of chimes in with that equity efficiency trade-off literature.
Okay, I think we have to, because we run a very tight hour, because a lot of people have to go, I know. But thank you all very much, but especially thank you to Misael for presenting the paper. Raises a lot of issues, and it's obviously, you know, there's a lot of nuances in there, but also, you know, I think it demonstrates there is a lot of work to do in this area still. So thank you very much to Misael, and thank you all for attending, and we will be in touch with future activities within the next couple of weeks. So thank you for attending. I should say Valerio Benedetto, who is on the call, helps run these, and thank you, Valerio.
Oh,
My name is Bruce Hollingsworth, and I work at Lancaster. We kind of co-run with Angela Boland, the health economics subgroup. Thank you all very much. Sorry for running over by 1 minute. We'll be better on time next time. So thank you all, and see you soon.